So next up is let me introduce CT Lin. He is a CMIO at UC Health in Colorado, and just really excited to hear some stories from you about your perspective on AI and ML in healthcare.
I very pretentiously titled my talk Sepsis, Machine Learning, and the Centaur. So here we go. Nothing to disclose other than ridiculous children without understanding of proper clothing choices. And if you watch movies, you understand that in our future, we don't need physicians or surgeons because the Prometheus MedPod will be your surgeon and diagnose you from a single scan, right? Notwithstanding the horrible outcomes that comes from this horror movie, the technology is spectacular, right? And yet this is all we get. What a load of baloney. All right, this unhappy physician can't even use the technology, yelling at the computer, nobody's happy, patient's not happy, right? So, all right, so here's your clinical case of in-hospital sepsis, which is a blood infection for those of you who are not clinicians. 47-year-old woman with multiple fracture repairs who was brought in from a car accident. And she's recuperating normally until day 3 when, unnoticed by her physician and nurse teams, her heart rate starts subtly rising, her blood pressure starts fluctuating, and her respiratory rate rises in such a subtle way that really the clinicians don't notice because they're busy doing other things. On day 5, 2 days later, the patient says, I feel terrible. She spikes a fever of 102, a lactate, which is one of the hallmarks of diagnosing sepsis, it's drawn, that level is high. There finally a diagnosis of sepsis is established. IV fluids are started, blood cultures are drawn, antibiotics are started. 2 further days later, respiratory failure. The infection has gotten worse. She's transferred to the ICU. She's put on a ventilator, a breathing machine to support her breathing. By day 14, a week later, she's on maximum support, has a cardiac arrest, and dies. This is not an uncommon phenomenon in our hospitals, right? Could we have detected sepsis earlier is the question. So why does it matter? Well, there are, turns out, more sepsis cases than heart attacks in this country. And then every hour, about 50 people die from sepsis. This is a big deal. Sepsis causes more deaths than prostate cancer, breast cancer, and HIV/AIDS combined, and cases have doubled in the last 10 years. It is not getting better. We are not doing a better job. So let's fix this, says the Pollyanna CMIO. Well, how hard can it be? Look, we just hired a couple of data scientists. Let's build a machine learning model that show these predictive results to doctors. The computer's never tired. We can teach the computer what to look for. How hard can it be? So our initial criteria for a good ML project, and I'll talk about additional new criteria going forward, and I would love a conversation about this from my colleagues here today. First you start with a creative pause of just wait a minute. Is this something we could do something about, right? Is there an opportunity here for a prediction? And then questions we have to ask ourselves. Do we have the data? Is there an effective action if we did have the data and the prediction? And is early action demonstrated to be helpful? Unfortunately, in the case of sepsis, all of these answers are yes. And then do we have an engaged, passionate operational leader, right? Because sometimes our data scientists get all excited about, well, we could make this prediction, and yet there's no one on the operational side who's interested in working with this prediction. Do we have a clear vision of our outcomes? And we'll talk more about this in the sepsis case. And is there a clear dependent variable? What is your dependent variable? How did you define that? And then finally, do we have a team that can act on these predictions? So here's a little bit about the algorithm. And as CMIO, I'm purely hand-waving here, how we made the sausage. So our data scientists met for weeks with our hospitalists, our critical care docs, our informatics clinicians, and our EHR database architects. We used 3 years of our EHR data. We built our own model. We did not use Epic's published foundation sepsis model. We chose a series of decision trees, an ensemble method, and then we consciously chose to maximize sensitivity at the cost of worse signal to noise, right? The quote was, "We can't miss any cases." So, and then we built this before implementing Epic's cognitive computer platform. We've since moved and migrated our tools to that platform. But again, that's details we can put to another time. And the question is, how did we do? So our first trial And that's not a great sign because, if there's a first trial, there's probably subsequent ones and failures to come. So here we go. We alert the bedside clinician and the nurse. So we did achieve 93% sensitivity, 85% specificity on our model. We added the sepsis score, this prediction score, into the patient lists on all of our med-surg units, on non-ICU units, where the nurse ratio is 1:5, and not every nurse is eyeballing every patient every minute of the day. We passively showed this alert to clinicians, nurses. We color-coded the score, and we thought, just like the movies, build it and they will come. And this is a snapshot of how it looks on the monitor. This is our pilot in the burn ICU. We have our patient identities, or at least our demographics here, and whether they're full code. And on the left side, scores from green, yellow to red. So was it effective? And it's not a smiley face? No. And why is that? Well, our nurses look like this, right? How many devices can you carry? Here's another one. The great thing is we're so well connected. Well, with this number of interruptions and alerts is a passive item, even if there's an additional alert, right? Nurses, we know from recent publications, talk about it's actually more disturbing to nurses when the unit goes quiet, right? Because we constantly have a barrage of sounds. The pump's malfunctioning. Oh, there's a slowdown in the such and such. Everything's going off all the time. And so adding a sepsis alert to something that's going to happen in 8 to 12 hours when nurses and doctors are dealing with crises at the moment, how effective is that? And here's another decision that came out to bite us, right? We chose high sensitivity, quote, don't miss any cases. And thus the signal to noise is not going to be great. We have a high alert volume. This is on a unit of about 30 patients. We'll receive 61 alerts per day coming in, of which there are maybe 1 or 2 true deteriorations. So right from the get-go, our signal to noise is not great. And can you imagine, CT-Lin announces, congratulations, we have a new predictive alert, and watch the column carefully. And after the first 24 investigations of, did that patient get worse? No. Did that patient get worse? No. Did that you know what? Forget it. This thing doesn't do anything. And by the 60th, where there's a true positive, and we caught it, right? Who's paying attention anymore? So our outcome, the score seems to be displaying appropriately. We got what we designed. However, right, at the end of our period of, I think it was 6 weeks, no change in the number of sepsis cases, no change in the number of unanticipated transfers to the ICU, no change in the mortality. Or rather, being very careful about our definitions, no change in unexpected mortality, because we do have palliative care cases where we do expect, right? There's no change in speed of placing orders for IV fluids, no change in speed to getting blood cultures or infusion of antibiotics. And of course, there's blowback from the clinicians. We are too busy to look. Did you not think we were working hard enough already? And you're going to give this thing that's going to maybe happen in 12 hours. And by the way, only 1 out of 60 is going to be a true positive? Seriously? You thought it was helpful to me? No. So here's our low signal to noise challenge, right? So our iterative testing, it's about 30 to 1. The good news is the algorithm did what we wanted. We detected every deterioration. We didn't miss any. But the bad is there's tremendous bedside team fatigue. It takes about 15 minutes to sit down and really think through a chart. How can we fix this, right? And so we have some ideas, and I'll come back to it. And then we also designed for deterioration in the next 8 hours. We arbitrarily, well, how far ahead do we want this prediction to occur? And we thought, well, 8 hours seems like a reasonable way of moving the needle, maybe an hour or two ahead, if we showed you what's happening in the next 8 hours. And it turns out the alert comes too late. Most of the time, by the time we push an alert to them, they go, yeah, don't bother me, I'm on it. And they already have detected it themselves clinically. And the question is, how do we fix this? And we then adjusted to a 12-hour prediction, which, as you'll see, did perform somewhat better for us. Which leads us to the 80-20 Pareto rule, right? And this is from a famous grandfather of informatics who I met with about 20 years ago at LDS Hospital, Reed Gardner. He says the success of a project is 80% about the social skills of those implementing the tools and only 20% about the technology. The technology is hard enough as it is, as I'm listening to Dr. Shah and realizing, ooh, there's a bunch of stuff we should have done to start off with a better tool. That's still 20% of the work because it's interacting with your end user, your operational team, where it's going to fly or not. And so we want to try to use communication to avoid, as I've seen too many times in my lifetime, the angry mob fun run. So our second trial, right? We partner with the Virtual Health Center, which we recently had stood up. This is a building in a separate part of Denver, and we have a critical care doctor and 3 to 4, depending on the shift, critical care nurses available 24/7. We watch all 12 UC Health hospitals. We add up to nearly 2,000 beds. This virtual health nurse can access the Epic chart, see the predictive scores and the tracking tools. We have access to, in many cases, a video camera into the patient room. We have direct communication by secure chat or messaging or pager number or phone number to the bedside nurse and the clinician. And over time, we've now created the authority for them to actually place the orders rather than try to trace down the doctor and go, can you please, order the lactate? And that in itself being a delay, we now have authority to place those orders, to call these sepsis alerts, to escalate care directly. This is what it looks like. This is back when we only had 6 monitors per ICU nurse. We're up to 8 now, and they have laptops open for the 9th screen because apparently that's just not enough display space to see everything. And here's an example of a clinical setting. It's not a sepsis case, but for example, the virtual health nurse helping the bedside nurse, a 56-year-old patient, recently had a CABG, coronary artery bypass graft, his heart bypass, 3 vessels. The VHC nurse was alerted to deterioration, respiratory rates 30, oxygen sat fell to 86%, and the nurse contacts the bedside nurse, who's busy all morning with another high acuity patient. The bedside nurse, with that alert, comes back over, finds the patient in a new trigeminy heart rhythm. So you listen to the heart, and now it's got an arrhythmia, something is going on. But they're quiet about it, and they don't feel it, right? And that's why they haven't pushed the nurse call button. The oxygen had to be increased to 7 liters to correct the oxygen desaturation. An EKG and a Chem7 are ordered, and we find low potassium, low magnesium. This is supplemented, and the heart rhythm resolves. Oxygen returns to the 3-liter requirement, and patient is successfully discharged home the next day, where you could imagine if this wasn't detected in time, a heart arrhythmia, a transfer to the ICU, a week-long extended stay. This is something that was saved because of this intervention. So thinking about sepsis care, it's complicated. It's hard to detect. Speed is critical. There's over 100+ tasks in the sepsis bundle, the known sort of, if you're doing everything right, there are 100 things you need to be doing to take care of sepsis properly. Our algorithm did create earlier signal, and having a dedicated team that's vigilant and consistent, right? Can you imagine? We have 6,000 providers and 12,000 nurses in our organization. Can we put them all through the same level of rigorous training for sepsis as we would train, a dozen virtual health nurses who know exactly what they're doing? Of course, the smaller team, highly trained, is going to be much more consistent and vigilant. And the centralized response improves consistency and speed. So just to lay out the workflow, before the virtual health center, we have a nurse, they chart the vitals. There's an alert that pops up to the bedside nurse. You're busy with another patient. You don't come back and log in for hours. So there's a delay in the alert not being seen. The nurse finally sees it, orders the sepsis protocol, draws the CBC and lactate. The lactate comes back, you're busy with a patient, and it's another hour before you log back in and see, oh, the lactate's high. I should probably do something. And there's an inconsistent timing on the nurse response. With the virtual health center, the nurse continues to chart the vitals. And then as soon as the vital alert fires, it fires to the virtual health nurse, who's sitting there just watching for something to come up. They do the chart biopsy. They do the 15 minutes of review. They filter out what they think are the false positives, and then they call in the orders. Here's the sepsis protocol. Call the nurse at the bedside. Please, can you drop everything? Go draw that lactate right now. And then when the alert comes back, it's not the bedside nurse who has to pick it up. The virtual health nurse sees the lactate, tracks the tasks and results, makes sure the hundreds of tasks are completed on time. They call the bedside nurse of the escalation. This is what we're doing. I'm starting the fluids. Please, get going on the antibiotics and so forth. And it's much less burden to the bedside nurse. So frontline nurses are too busy. Show the predictive scores to a dedicated team. There's a 30x improvement in signal to noise because you have someone else filtering out the false positives, and there's significant time savings all around. So what we're seeing as a result of this dedicated team, 77-minute faster time to fluids, 49 minutes faster time to antibiotics. That cuts the time in half. And if you look at this on the outcomes graph, right, well, actually, even before we had any alerts going into the system, we had about 210 minute delay from detection to treatment, we actually had reduced it to 94 minutes before we started both the virtual health center and the predictive alert. And those 94 minutes were cut in half down to 45 minutes. And that outcome is that those 49 minutes is an equivalent of 211 more lives just within our health system saved per year from sepsis deterioration. It's a big deal. So what did we learn? Choose and design your machine learning carefully. This is really hard work. And then even that, it's not enough. You need to design teamwork around it. And this is kind of how we're thinking about, as we think about the next ML project, how do you decide on what's a good project? And I think we're getting closer to sort of a way of approaching new systems and new departments and saying, all right, we have an ML team. What's a good project? And so, for example, how should we do this? Why this project? And describe the strategic priority. Is there an operational clinical leadership support? And maybe there isn't, and you have to move on. Who's the champion? What are you wanting to predict? Where's the data? Is it in the EHR? And if it's not, can we access it? Is the data timely or delayed? That's fascinating because, in the past, nurses would scribble the vitals on paper and they're so busy that they, at the end of an 8-hour shift, would then enter all the vitals. Well, how does that help anybody? We have to actually retrain our frontline staff so that the data is captured in a timely way. Then how much data is missing? Is this an optional charting element or a mandatory charting element? Is 3/4 of your data missing? In which case, this is not going to be a good model. Who are your patients? What is the action you want to take? Just because you can do a prediction doesn't mean you actually have an action you can take on it. And then how do we design it? How far in the future do you need the prediction? How many patients are you going to implement? Do you have the resources to do it? Who's going to act on the prediction? Just because you show it to the bedside clinician, as you see, you're not going to move the needle necessarily. And then how sensitive and specific? And in hindsight, would we design the sensitivity the same way? Probably not. And then how do you improve? How will you know you've succeeded? What are your metrics? When do you go back and redesign and redeploy? So I'm thinking the Centaur is the human-computer hybrid, right? In Greek mythology, this is half man, half horse. In our case, thinking about actually examples elsewhere, in chess, for example, as I understand, unlimited chess tournaments in the world now are beaten by Centaur teams. Human-only teams and machine-only teams always lose to those who are both. And I think the most recent grand champion was 2 mid-level grandmasters and 3 AIs. That was the team that actually won the championship. So how interesting that is. And for us, this would be the machine learning predictive algorithm plus the teamwork of a virtual health center plus thoughtful teamwork with the bedside nurse and redesigning those workflows until it works. So it's human-computer collaboration is required, I think, in our era, until some future date when the Terminator comes and offs us all or takes over all of our jobs. Human-computer collaboration is required for successful machine learning and healthcare implementation. So the difference between good and great, 211 lives per year. And thanks to our sepsis team. Now, if there is time, I asked Vikas for permission to do something unusual. Vikas, is that all right?
Absolutely. Go
so
for it.
Here's the lyrics. I'll just have you kind of a quick glance at it, but I'll just leave it up. But I have a song for you that is a Hospital of the Rising Sun. I write parody ukulele songs for EHR deployments, and I have a version that's actually relevant to predictive analytics.
Can someone screenshot this? I'm prepping for Q&A, and this needs to get screenshot.
There is a hospital in Colorado they call the Rising Sun, and it's been the ruin of many a poor doc, and God, I know I'm one. Now the only thing that a doctor needs is a paper sheet and a pen to jot a prescription hard to read. An error on its way he sends. One saw computer screens replacing those old charts. The floor swarmed with eager red shirts. No place for us old farts. At first, we had a tough old time. Pandemic fever on the rise. We were not so sure that we would survive, heading with keyboards and mice to sanitize. Oh, mother, tell your children not to do what I have done. I've ignored those alerts and reminders in the hospital of the rising sun. But then something changed in the air one night. Those sepsis cases, we had none. With predictive alerts and surveillance teams in the hospital of the rising sun. Well, I got one foot in my deep, dark past and one foot in the car. I'm going back to Colorado to be an epic star. Well, there is a hospital in Colorado they call the Rising Sun, and it's been the savior of many a poor doc. And God,